Welcome, fellow students of human anatomy and aspiring clinicians, to another deep dive. Have you ever really paused to appreciate the architectural marvel that supports our every step? I mean, the intricate balance of bones, muscles, nerves, everything that lets us stand, walk, run, explore. Today, we're taking a focused, practical deep dive into one of the body's most remarkable and, well, frequently injured regions, the leg, ankle, and foot.
It truly is a masterpiece of biomechanics, a system designed for both immense strength and, nuanced flexibility. And for you, our medical student listeners, this deep dive isn't just about memorizing structures. It's really about understanding the why behind movements, the how behind stability, and the what of common clinical conditions. We want to help you grasp these concepts in a way that's, well, easy to understand, retain, and recall when you're facing a patient.
Absolutely. Think of this as your essential anatomical cheat sheet, filled with memorable anchors and clear, actionable insights. We've poured over the material you've shared, and we're here to guide you, extracting those crucial nuggets of knowledge. So let's begin by exploring the very foundation of our upright movement, the gait cycle. Okay, our journey through the leg, ankle, and foot truly starts with how we move through space, the gait cycle. It's more than just walking. It's this beautifully orchestrated, energy-efficient advancement of the body. It's like a perfectly choreographed dance where your foot changes its role and shape dynamically at various points, constantly adapting.
Precisely. We define a full gait cycle as a complete stride, and it has two primary phases that dictate everything. The stance phase, where your foot is on the ground bearing weight. That typically accounts for about 60% of the cycle. Then there's the swing phase, where your foot is in the air, advancing forward, making up the remaining 40%. Understanding these two main phases is really your fundamental anchor for comprehending lower limb mechanics.
Right. Now, let's introduce the main architectural players, the bones. In the lower leg, we have that dynamic duo, the tibia and the fibula. The tibia, your shin bone, is truly the sturdy pillar. It's the second largest bone in the body after the femur, its primary job. Transmitting weight from the femur down to the foot is built for strength. The fibula, on the other hand, is like the ankle's loyal, slender stabilizer. What's truly insightful here is why it doesn't bear much direct weight.
Exactly. Its primary role is to be a crucial lever arm, an attachment point for muscles, especially those involved in turning your foot outwards, allowing for dynamic adaptation to uneven surfaces. Its slender structure optimizes the stability function without adding unnecessary weight-bearing stress to the knee joint above it.
That differentiation is just key, isn't it? Not just anatomically, but clinically.
Absolutely. And speaking of weight-bearing and intricate structures, let's consider the complex mosaic of bones within the foot itself. We start with the talus, which is a vital component of the ankle joint linking the leg to the foot. Then the substantial calcaneus, the heel bone, forms the bony mass of your heel first to land during that initial heel strike in gait.
Right, the impact point.
Exactly. From there, we transition into the midfoot, a group of smaller bones, including the navicular, the three cuneiforms, medial, intermediate, and lateral, and the cuboid. These pave the way to the metatarsals, the long bones of your foot, and finally the phalanges, your toe bones. It's a complex arrangement, all designed for flexibility and efficient load distribution. And a fascinating little detail. The second digit acts as the central axis for the subtle abduction and adduction movements of your other toes. Gives it a unique biomechanical role.
You know, that initial impact on the calcaneus during heel strike really makes you think about the forces at play. And for you, a future clinician, it raises a truly critical question. If you see a calcaneal fracture, maybe from a high-energy fall, why might your mind immediately jump to checking for injuries higher up the body, perhaps even in the spine? It's a connection we'll fully unpack a little later, but it highlights that whole body kinetic chain reaction. Keep that thought in your mind.
Good point.
So with that incredible bony framework established, the question naturally becomes, what actually moves these bones? The dynamic forces. Muscles, of course. In the foot, we broadly categorize them into two main types. Intrinsic muscles, which are like the local team's origin and insertion entirely within the foot. Then we have extrinsic muscles, the visiting teams, originating outside the foot, usually on the lower leg, but sending their tendons down to insert within the foot.
Those intrinsic muscles, arranged quite ingeniously in 4 distinct layers, are far more vital than they often get credit for. They're like dynamic ligaments, constantly adjusting to support the foot arches and providing fine-tuned assistance to your digits during push-off. Their weakness can profoundly impact foot mechanics, even lead to arch collapse, so their role in stability and efficient gait is critical.
What's truly fascinating is how muscle architecture directly dictates function. Think about it. Thick, short muscles generate immense force, perfect for power. Long, thin muscles, on the other hand, build for velocity, enabling rapid movements. And those muscles with long tendons, masters of efficiency, facilitating large movements at the ankle and foot with relatively little actual muscle contraction up in the leg.
Right.
Now let's organize those extrinsic muscles at the lower leg into what we call compartments. These are essentially functional neighborhoods, each enclosed by tough fascial tissue, each with its own specific job, dedicated nerve, and blood supply.
Indeed. We divide the extrinsic lower leg muscles into three primary compartments: the anterior, posterior, and lateral. A helpful little anchor to remember them, maybe in order of action when you walk, is to think. Always plant legs. Anterior, posterior, lateral.
Nice.
The anterior compartment, located on the front of your shin, is primarily responsible for dorsiflexion of the ankle that's lifting your foot and toes upwards, also extending your digits and foot inversion. Its nerve supply comes from the deep fibular nerve, a branch of the common fibular, and its blood supply from the anterior tibial artery.
Okay, thinking about those compartments. What happens when a nerve supply is compromised? For instance, with the anterior compartment, if the common fibular nerve, which we know is quite exposed as it wraps around the fibular neck, gets damaged, what would be the immediate noticeable impact on a patient's movement? And why is that specific condition, known as foot drop, so dangerous for daily life?
Good question. Well, shifting to the posterior compartment, this powerful group handles the opposite actions, primarily plantar flexion, pointing your toes downwards, flexing your digits, and assisting in foot inversion. This compartment gets its neural input from the tibial nerve and its vascular supply from the posterior tibial artery. Loss of function here means weak or absent push-off during gait, and it's also where you might encounter conditions like Achilles tendinopathy or even rupture, given the immense forces these muscles generate. An important clinical point: many neurovascular structures here are located deep, well protected by the substantial soleus muscle.
And finally, the lateral fibular compartment. This is your reversion specialist. It's all about turning the sole of your foot outwards. Nerve supply is the superficial fibular nerve, blood supply from the fibular artery. Here's a neat clinical connection. An inversion injury, like twisting your ankle inwards, can sometimes cause an avulsion fracture from the tuberosity of the fifth metatarsal.
Right, where the bone gets pulled off.
Exactly. An avulsion fracture is where a strong ligament or tendon pulls a small piece of bone away from its attachment. It happens because the fibularis brevis muscle inserts precisely there, and that sudden force can literally pull off a chunk of bone.
That's an excellent connection, and it brings us back to your earlier question about the common fibular nerve. If that nerve is damaged, say, from a fibular neck fracture or even prolonged compression, its deep fibular nerve branch is severely affected. This directly causes paralysis of dorsiflexion, leading to the condition known as foot drop.
Oh, okay.
And this is dangerous because the patient simply cannot lift the front of their foot. It drags on the ground as they try to walk. This significantly increases their risk of tripping and falling, severely impacting their mobility and safety in daily life. It really makes you appreciate every step, doesn't it? Just imagine the daily challenge of navigating stairs or even just a sidewalk crack.
Wow, yeah. That explanation of foot drop really highlights how a single nerve injury can have such a profound impact. Okay, so with our bones and muscles now in focus, let's explore how these components connect and move. The ankle joint itself. It's a synovial hinge joint formed by the articulation of the talus with the distal ends of the tibia and fibula. Primarily allows for dorsiflexion and plantar flexion, those crucial up and down movements.
Right, but what's truly intriguing is that despite the ankle joint allowing for a significant range of plantar flexion, it's actually least stable in this very position. Can you think about why that might be? From a purely mechanical perspective, it's critical for understanding ankle injuries.
Ooh, good challenge for our listeners.
Yeah.
Keep that in mind. Meanwhile, the more complex movements of inversion turning the sole inwards and eversion turning the sole outwards primarily occur at the subtalar joint. This joint, just below the ankle joint, allows for a sophisticated triplanar motion, enables your foot to adapt to uneven surfaces. These joints are far from simple hinges.
Exactly. And maintaining stability in these joints is paramount, largely due to strong collateral ligaments. Think of these like the foot's high tensile cables, providing critical tensile strength to resist rotational and side-to-side forces, holding everything together. On the medial side, we find the exceptionally strong medial collateral deltoid ligament complex. It's a broad, fan-shaped ligament designed to prevent excessive foot eversion. If damaged, which is less common due to its strength, it's typically from extreme eversion, often causing sprains or even those avulsion fractures of the malleoli.
And then on the lateral side, we have three distinct lateral collateral ligaments. These are generally injured more frequently than their medial counterparts. The anterior talofibular ligament, ATFL, is the most commonly injured of the three, typically by excessive inversion, that classic ankle sprain we all know or have probably experienced. We can even assess for an ATFL tear with an anterior drawer test, where you gently try to pull the talus forward, mimicking the movement that damages it. The malleoli, those prominent bony bumps at your ankle, are also quite susceptible to avulsion fractures from inversion, eversion, or rotational stresses.
And that brings us back nicely to my question about ankle stability. The ankle joint is indeed least stable during plantar flexion. Why? Because the talus, the bone articulating within the ankle joint, is wider anteriorly and narrower posteriorly. When the foot is in dorsiflexion, that wider part of the talus is tightly wedged between the tibia and fibula's malleoli, providing significant bony stability.
Oh, okay, like a wedge.
Exactly. But in plantar flexion, the narrower posterior part of the talus allows for more play or looseness within the joint. This reduced bony congruence makes the ankle more susceptible to injury, particularly inversion sprains, because the inherent bony architecture offers less stability in that position.
That explanation truly clarifies why inversion sprains are so common. Makes perfect sense. It seems intricate stability is also key when we consider the foot's natural suspension bridges, the incredible foot arches. These aren't just for show, they're your body's natural shock absorbers and propulsion systems. Absolutely crucial for distributing pressure evenly across the foot and generating efficient push-off during movement. These arches are dynamically maintained by strong ligaments, like the long plantar, short plantar, and spring ligaments, along with the active dynamic support of those intrinsic muscles we discussed. They act like living guy wires.
And it's right here, in the context of these crucial supporting structures, that conditions like plantar fasciopathy often arise. This is where that tough, fibrous band on the sole of your foot, the plantar fascia, gets inflamed. When that springboard tissue loses its resilience or gets overstressed, it can lead to intense heel pain, especially with the first steps in the morning. Profoundly impacts daily life.
Definitely.
Now, let's also connect back to your very first question about the calcaneal fracture. Remember that?
Yes, the high energy impact and checking higher up.
Exactly. When a patient sustains a calcaneal fracture from high-energy trauma, it's a profound reminder that the human body functions as a single, interconnected kinetic chain. The sheer force of impact doesn't simply dissipate at the heel. It's transmitted upwards through the entire skeletal system. This energy can continue to travel, potentially causing thoracolumbar vertebral fractures in the spine, or in some extreme cases, even Atlas C1 fractures in the neck. That's why a comprehensive proximal injury assessment, meaning looking for injuries higher up the body, is absolutely crucial in such cases. You're looking for where that transmitted force might have caused further, sometimes hidden damage.
It's an incredible testament to the body's interconnectedness. Really drives home that point. Our body also organizes its intricate structures through fascia, that tough connective tissue that compartmentalizes muscles, nerves, and vessels into contained spaces. This organization is clinically vital. Think about compartment syndrome, where a swelling within a confined compartment can compress nerves and vessels, causing pain and tissue damage. It's also crucial for localizing infections. The plantar foot, specifically, is cleverly divided into 4 distinct fascial compartments, each protecting its contents.
And these fascial bands also take on specialized forms, creating structures called retinacula. I like to think of them as tendon seatbelts. Strong bands of fascia that essentially strap tendons down, preventing them from bowstringing, lifting away from the bone, ensuring smooth, efficient movement across joints. A prime example, and one of great clinical significance, is the flexor retinaculum, a thick band forming the roof of a crucial passageway, the tarsal tunnel. The floor is largely the medial calcaneus.
The tarsal tunnel. It always strikes me as such a high-stakes area. It truly is like a vital access point from the posterior leg into the foot, packed with so much important stuff. And for our medical students, there's that fantastic mnemonic to remember its contents as you trace them from anterior to posterior. Tom, Dick, and very nervous Harry.
Let's quickly unpack that acronym for you. It's a high-yield memory tool. The T stands for the tendon of tibialis posterior, D for the tendon of flexor digitorum longus, A for the posterior tibial artery, V for the accompanying veins, N for the tibial nerve, and finally H for the tendon of flexor hallucis longus.
Got it.
When the tibial nerve within this tunnel gets compressed, maybe by swelling or a cyst, it causes pain, numbness, tingling on the sole of the foot. That's tarsal tunnel syndrome. Clinically, you can even palpate the posterior tibial pulse just behind the medial malleolus, along a line passing between the malleolus and calcaneus. It's a key spot for quickly assessing the foot's vascular status.
Right. Now let's follow the blood flow, the vital arterial supply nourishing these structures. Primary supply comes from the popliteal artery, which, after passing the knee, splits. The anterior tibial artery supplies the anterior compartment, then continues distally as the dorsalis pedis artery on the top of the foot. That's a pulse you'll definitely be checking in clinical practice, a crucial indicator of distal perfusion.
Absolutely.
Meanwhile, the posterior tibial artery feeds the posterior compartment and also gives off the fibular artery for the lateral compartment. These arteries then branch further into the intricate networks of plantar and dorsal digital arteries supplying your toes.
And for venous return, we have two systems. A deep system following the arteries, and a superficial system, which is clinically quite important. So imagine you're in an emergency, needing rapid intravenous access in the lower limb. Where's a reliable superficial vein you might target for a venous cutdown, and why is that specific location anatomically advantageous for quick, dependable access?
Another good clinical question. Okay, finally, let's quickly chart the intricate nerves bringing sensation and movement. The main nerve for the leg is the mighty sciatic nerve, which typically divides, usually behind the knee, into the tibial nerve. That's primarily for the posterior compartment muscles and sensory innervation of the plantar foot, and the common fibular peroneal nerve. Remember, that common fibular nerve is quite vulnerable as it passes superficially around the fibular neck, highly susceptible to compression or injury.
Very true.
It then further divides into the deep fibular nerve, supplying the anterior compartment muscles, some dorsal foot muscles, and sensation between digits 1 and 2, and the superficial fibular nerve, supplying the lateral compartment muscles and providing sensory innervation over most of the dorsal foot.
Okay, and to answer your question on emergency IV access, the great long saphenous vein is your target. It consistently passes approximately 1 to 2 centimeter anterior to the medial malleolus. Its consistent superficial location, combined with its relatively large caliber, makes it comparably easy to locate and access for a venous cutdown. Provides quick, reliable access in a critical emergency. It's really a key anatomical landmark for urgent care scenarios.
Excellent. Good to know.
And speaking of nerves and sensation, it's worth noting conditions like Morton's neuroma. That's a painful thickening or growth on a digital nerve, often between digits 3 and 4. Can make you feel like you're walking on a persistent pebble. Shows just how sensitive these distal nerve branches can be. The plantar foot, by the way, is incredibly sensitive, innervated by 5 different nerves, which means effective local anesthesia requires blocking all 5 of them.
Wow, 5 nerve just for the soul. This deep dive truly highlights how all these seemingly individual anatomical structures are profoundly interconnected. Leads right into the vast array of clinical conditions we've touched upon, from the heel pain of plantar fasciopathy to nerve compression and tarsal tunnel syndrome or Morton's neuroma. Understanding the intricate anatomy is the absolute foundation for effective diagnosis and treatment.
Precisely. Knowing these details allows you to connect a patient's symptoms to specific structures, predict the impact of injury on function, and ultimately approach patient care with a comprehensive, holistic understanding. Goes far beyond just memorizing facts.
So as we wrap up this deep dive into the incredible leg, ankle, and foot, here's a final provocative thought for you to mull over. How does a subtle difference in individual foot arch height, or even a past, seemingly minor ankle sprain that might have altered ligamentous tension, how does that impact not just localized foot mechanics, but potentially influence forces transmitted all the way up the kinetic chain, to the knee, hip, even the spine, during a lifetime of movement and activity?
Something to think about.
Keep exploring, keep questioning, and keep connecting those crucial dots. Your journey into the human body is just beginning, and with each deep dive, you're building an ever stronger foundation for your medical career.
The deeper you delve into these systems, the clearer the complex, beautiful picture becomes. Until next time, stay curious and keep learning.